So we have another complication where I did have a fracture for an elderly patient. So this was a 73-year-old lady. She was a seronegative RA, on and off medication, housebound, and was not able to carry out activity of daily living with very poor knee society and function scores, reasonable BMI, and in a lot of pain. So she had a varus of 20 and on the right side, and that of about 28 on the left side. She had a stiff non-union of the proximal third of the tibia on the left side, and she had a fixed flexion deformity on both the sides, more on the left than on the right. And she had grade 2 instability on both the sides with distal pulses which were palpable. So this is what she looked like. So my question to the panel would be, what would be your take? What would you do? Just fix the fracture femur and let her be, or would you like to do something else? Fracture of the tibia, sorry. So, treat the non-union or treat the non-union and arthritis?
It can be treated with a TKR with a long stem. If we get that long stem, at least 2 to 3 centimeters.
So how many of the panel will treat just the non-union, and how many will treat the non-union and the arthritis of the knee? Okay, so how many will treat just the non-union of the tibia on the left side? A show of hands. Only, none. How many will treat the non-union of the tibia and the knee on the left side? How many will do both sides? So how many of you will do it simultaneously, and how many will stage it?
Depends on fitness.
Okay, so very important point here is that depends upon the comorbidities and depends upon the fitness and the kind of surgery a patient can take. All right. Okay, so we decided to treat both the arthritis and the stiff non-union. So obviously we did a deformity planning for this particular patient, and the basic things that we needed to address here were that there was a periarticular defect on the tibia. There was a deformity with a cora walking almost near or outside the condyle. And obviously she was osteopenic, and she had a very significant arthritis. So there is a classification by Dr. Mulaji based on 43 or 47 patients where they have defined extra-articular deformity into multiple types, and one of the deformities is an ununited deformity. And the basic rule of that deformity says that if your distal mechanical axis stays within the condyle, and that is a paper by Wang in 2005, then you can do an intra-articular correction of the deformity. Otherwise, you need to do an extra-articular correction and stage the deformity. So these are the options which we will do. And the panel is very clear that they want both sides need arthritis correction, and the left side needs the non-union correction, and they will do it staged or simultaneous depending upon how fit the patient is. So we decided to do a left side correction. These were the basic challenges that we were needing to face, and this is what the knee looked like. So any comments from the panel?
I will definitely add a plate there.
Atul?
Atul wants to add a plate here. Even I agree with Atul that I would have supplemented it with a plate or taken a longer stem. But
so I will tell you a little bit about where and what has been done here. So we did the femur first, as I routinely do the femur first, and then we prepared the tibia with an extramedullary jig. And normally we would be able to correct these non-unions by either a hemicorticotomy or a hemiosteotomy, or by just doing a valgus stress to the tibia. And if we are able to do that, then you can actually negotiate an intramedullary jig into the tibia, and you can do your tibial cut, and you can do everything there. And in those cases, one can just do without an additional fixation. But in this patient, we were not able to correct, so we did a hemiosteotomy of the tibia. I put in a uni cortical plate just to hold the correction. Still, I was not able to manage. So I did an osteotomy of the fibula distally, just so that I could correct the tibia and get a proper alignment.
Yes,
So-
Raju has a comment.
No, I think you went the first step would be a fibulectomy. Second step, we went the wrong way around actually. First step would be a fibulectomy. Second step would be the non-union deformity correction and put a plate on. Initially it's a temporary plate. Then you go on, do your knee, do your femur, do your tibia, have your intermedullary jig ready. Then at the end, change the plate to initially, because what happens is the ones that I've done is I've changed the plate to a longer plate. Initially, I
Yeah.
put a 4-hole plate just to hold my osteotomy, and later on, what I do once I have my stem down, this starts interfering. So I've taken a couple of screws out, and then put a longer plate spanning down from top to bottom.
Whole of tibia.
Absolutely, because the problem is the tip of that extender there is going to start wafting, and there's high chance it's going to crack there.
Okay, point very well taken.
Wow.
So she started walking, and on day 16, she comes back exactly because the fibulotomy, which was done on the fibula, created an instability situation probably, and where the patient had a problem. So, what do you do now?
Had you seen the case, Raju, or you just predicted it?
No, because this is basic steps of management. It's
No, no.
just when I've done a couple of
Cracking
them.
below that.
I've done a couple of them, not many, 2, maybe 3 of them, and I've been involved with my colleagues with 2 more of them. So this is
Fantastic.
step 1, 2, 3, 4. Fibula first, tibia, non-union, put a small plate, go do your this thing, intermedullary jig.
Right, so it could have been prevented with a long
Then,
plate.
and it's just not the fibula wise. This is because of the stem. The stem is a great stress riser if it's so unstable, especially rheumatoid, and these happens with rheumatoid and osteoporotic bones.
So the experience with
Rattles.
stems is that they are very stable if you can get a good, fixation across the stem. But the longer the stem, the more proximal stress shielding you cause. So in this case, probably a plate would have been a
plate
safer
is
option.
essential.
Absolutely,
And
point
the
well
other thing
taken.
is that there's the recent
So
studies
what
on
do
the
we
stem.
do now?
With a longer stem in a tibia, the tibia also has a little bit bow, like a femur. And that always touches the anterolateral cortex. And there are chances microfractures are there and patient when walks, breaks it. The long stem, very long stem in a tibia is a little bit problem. So they need bridging always.
So short stem and a plate, a bridging
So
plate.
there are ways to tackle long stems. You can do a hybrid cementation, or you can do a cementation, but having a fracture, probably we did a hybrid cementation and tried to put a stem across. But yes, probably a plate was a safer option. But what do you do now? You land up with this situation. What to do now?
Atul, now.
I will fix this from top to bottom with the plate and bone
Great.
graft.
Okay.
So anyone else who wants to revise?
Fixed, it's too solidly fixed. I mean, your tibia, I've done it so well. I've been taking it out.
I think the joint is well fixed.
It's well
Yeah.
fixed.
So the
now we are
basic.
dealing with a type 3 periprosthetic fracture, so a long plate is
Absolutely.
allowed.
So very important is it's a Felix classification. So this is a type 3 periprosthetic fracture. The joint is well fixed. So the joint, if it is unstable, it needs to be revised. If the joint is stable, you can do a fixation. So that's where we are coming from, type A and type B. Type A is a fracture with a stable prosthesis. Type B is where there is an evidence of loosening. And type 3 is an intraoperative fracture. So very often we do have these intraoperative fractures, but they do go undetected. So one has to be very careful. And probably a plate in the first instance was in order, which I missed to put. So we took them back. The plan was to do we did a root cause analysis. Obviously, an osteopenic patient with a very osteoporotic right side, which was not fixed. So probably, even despite the bracing of the right knee, the loading on the left side was too much. Then we did a fibula osteotomy, which probably created a secondary instability. Then we had a unicortical plate, which added to the instability on the fracture side. And the contralateral knee, which caused a problem. So the planning was we basically analyzed the length of the plate that we wanted to take. The fixation strategy was that we did a tense nail of the fibula just to get the alignment back at the level of the fracture site. And then we did a spanning fixation with a plate. Obviously, there is a difficulty in negotiating the screws to both sides of the stem. But that was managed. You have to see oblique views and you can do a fixation. So your comment on the fixation now.
Maybe this looks good, but maybe I'm being a bit over this thing. I would possibly, if possible, if my skin bridge allows it, put a plate on both sides on this.
Say again,
Put a
please.
put a MIPO recon plate on the medial side also.
Put a MIPO on medial side.
Medial side, so I get a nice solidus.
Rheumatoid on and off medication. Very
This is
poor
a small
bone
MIPO.
quality.
So what I would do is this: you got an incision.
And tibia.
I'm just a little, just one small little incision, 3 screws below, and 2 screws on top. Maybe I mean just thinking aloud.
Okay.
I would
rheumatoid
use
Bone
a,
grafting is mandatory here.
I
bone
think
grafting.
a multi-lock, I mean a variable angle LCP which you get for the entire length of the tibia serves an excellent purpose when you have a periprosthetic knee like that. It allows you to put angle your screws where there is adequate bone.
Okay. Great. Point taken. Atul, you were saying something.
Bone grafted.
Bone grafted. Yeah. I mean, you
I
can do a bone grafted. That was done on the primary fixation
Or
itself.
demineralized bone matrix.
Yeah, you could use
TBM.
support augmentation of the fracture side
Is
because you want
rheumatoid.
a fracture union. So
What approach did you use for
another
this?
question is
Abhay, which approach did you use?
just
haven't-
just MIPO.
Just
One
MIPO, just
small
top.
incision on top.
So you had another
one small
incision.
down, just tunneled it and put in a plate.
Lateral MIPO.
Yeah. So the important thing was that
Fibula
the
is
fibular
fixed.
tense did
Fibula
the
is
reduction,
fixed.
and then it was just stabilization. So another question is, she has a right side. When do you mobilize and when do you get her to weight bear? That's question number 1. The panel.
Not till union.
Full weight bearing by end of 4 months.
Not till union.
Not
you
till
see-
union. Okay.
till you see
is the
some amount of
panel
bone there.
Uniformly on that. Okay. And when do you do the? Do you mobilize and weight bear her before the right side, or you do the right side and then mobilize her?
Ideally do the
Mobilize
right
with the
side
right
and then
So you right side, do the right side because otherwise you're really stuck. So at least right side is there. At least one side, one axis taken care of. And I'll just like to differ maybe regarding mobilization. Again, if you keep them off the legs too long, the bone is going to start disappearing.
Absolutely.
So I would possibly, because it's transverse fracture, maybe 3-4 weeks down, give her a functional cast brace, removable functional cast brace, and get a mobilization functional cast brace.
So the contralateral side is equally bad. The contralateral side. So the basic thought process is that in an elderly you need to mobilize, especially with a rheumatoid, the quality of bone stock. If you immobilize them for too long and wait for fracture healing, which can take 3 to 6 months,
I
is
mean
too
if
long
you
a
would
time.
start on teriparatide or something like that.
Yeah, so one needs to start medical augmentation for these fractures, and we waited for about 3.5, 4 months. She came back at 4.5 months. She was showing reasonably good union, and we did the contralateral side, and then she got her around to walking very comfortably. And when we did the right side, we took off the fibular nail. So I don't have the X-rays right now of that patient of the right side, but she's doing perfectly all right and walking well.
Great. Fine. So nice case. Abhay, I would
I've learned something today. I think today I learned from you after fibulectomy, I think putting a tense nail primarily. I've learned it from you today.
So it is a
That-
problem. I did not do it. It's not my first choice go-to, but I did it because that
Fantastic,
was
I
the only
learned.
thing to
but
get
it
a
has helped
correction.
you.
That's what I learned, man. This is fantastic because if I
Raju,
do a case
your
like this,
case.